Good morning and welcome to my YouTube channel Painfree Partha, and the slides also can be downloadable from painfreepartha.com. Free download and free editable. So today we are going to tell something about aortic stenosis. I'm not going to tell very deeply. I'm going to touch about the fundamentals so that we need to know all these things, the must know areas, and go about in anesthetizing any patient with these disease. So what is the incidence? We can see it is 1 to 2% in individuals in 65 to 75. It's around 3 to 73 to 5%. So 5% of your patients 75 years will get this aortic stenosis. The normal aortic valve area is around 2.5 to 3.5 square meters in adults. A narrowed aortic valve obstructs blood flow from LV to the aorta. So here you can see LA and the blood is coming. The left LV is pumping into the aorta. There is an obstruction here. So that is a narrow aortic valve obstructs blood flow from LV to aorta. So what is the etiology? We know it is 3 to 5%. Congenital or acquired. Congenital means bicuspid. Usually this aortic valve will have 3 cusps. Now if you have only 2 cusps, then it is bicuspid aortic valve. Acquired, it may be rheumatic, calcification, SLE and irradiation. Where is the site? It may also be supravalvular, can be subvalvular also, or else it can be a subvalvular extension of a valvular also. So if you want to go into the etiology, it is commonly bicuspid and calcification, then comes rheumatic. So these are all the etiology of aortic stenosis. What is the pathophysiology? Okay, it gets obstructed mildly. Aortic stenosis. LV cannot push. LV, what does that do? I cannot push. The LV does this by hypertrophy. This is what I call as pressure hypertrophy or concentric hypertrophy. This develops a pressure gradient so that the blood is pumped into the aorta. Now, there is no reduction of cardiac output. This is possible. The LV strains, it increases the pressure gradient, pushes through a narrow aortic valve. Then the cardiac output is maintained, not much of symptoms. Now, the hypertrophied ventricle, what happens to the hypertrophied ventricle? It becomes stiff. We know a stiff ventricle is less compliant. So, whenever LA and the LV blood is coming, it is less compliant or it is stiff. So, it is not receiving blood as easily as before. So it needs an atrial contraction to push the blood from LA to LV. So instead of 20% of the atrial systole need, you need 40% of this blood is coming from LA to LV because of atrial systole. 40%. So that is the rule of good atrial contraction in a patient with a hypertrophied LV where the filling pressures are high. What do you mean by that? The LA to LV, it fills. The pressure is raised. It is less compliant. It becomes stiff. All these things make the atrial systole at the end of diastole to be more important in these patients. Left off, so as soon as there is a hypertrophy, automatically it needs more oxygen. Now, oxygen supply is reduced owing to a relatively low aortic pressure with an increased left ventricular diastolic pressure. So, we all know that coronary circulation is under diastole. Now, your end diastolic pressure in the ventricles is higher. Coronary pressure is there, the aortic pressure is less. So, from there, the pressure is little less, and this is going high, high, and high. Now, how can the coronaries get perfused well? Coronaries are normal. There is no obstruction. There is no plaque formation. But it needs a pressure gradient from aorta in the diastole to LV in the diastole. If this gradient is decreased, then your perfusion is less, and these patients will have and angina or ischemic symptoms in the presence of normal coronaries. The ventricles become sensitive to changes in preload, dependent on the maintenance of sinus rhythm, susceptible to ischemia whenever the pressure is reduced. So we need good preload also, because in the LA itself there is less blood. Then where will it push? So preload should be good. The atrial systole should be good. Arrhythmia should not be there. Then where yes, we are. The diastolic pressure should also be good to perfuse the coronaries. So if it doesn't match, then slowly the cardiac output falls. Contracting. Pressure is not enough. So LV output falls. So LV dilatation occurs. They may go for death in 3 to 4 years. Now I'm going to see the pathophysiology again. Now this is LV, this is aorta, and this is the aortic stenosis. Now, if it normally it is 120, it is around 115. If you see a pressure gradient of 5 is there, but now you have the because of the stenosis here, the pressure P1 goes to 130 to 150. Now here it is 130 or 150. Then only it can push because this is stenosis. Now we need this ventricle is going to hypertrophy, and this hypertrophied ventricle needs more oxygen. But here the pressure difference is more. Here it is less and here it is more. So left ventricular end-diastolic pressure is more. And here this is less. So from there into the coronaries it is less. So they may have ischemia in the presence of normal coronaries. The LA will contribute to 40%. If it goes into left the atrial fibrillation, think of it. That is the problem. So maintenance of sinus rhythm, because left atrial systole is important to contribute to the left ventricular filling by 40% instead of 20% in normal individuals. So already we have told P2, P1 coronary vasculature. Preload is also important. We need more blood to flow, otherwise there is no. So because we know, because the more the work, you can see the right arm of Kapil Dev is little hypertrophy. So any work here, high pressure, automatically this hypertrophy. Now the LVH pressure gradient rises, filling pressure rises, the LA pressure rises, importance of atrial systole, less blood in the LA, preload danger. Slowly the LA may go for a backward failure. Or if the stenosis is there and the patient is not able to pump into the aorta, then the perfusion may be problematic. And if your SVR suddenly decreased, the diastolic pressure here is less and there is no coronary perfusion. The normal tricuspid, that means three cusps of an aortic valve, is a bicuspid valve. So systole in diastole. See here, because in systole it has to open like this, but a bicuspid valve can open only like this. And a calcific tricuspid valve will open only minute. So what is mild is, what is moderate? We know it is around 2.5. More than that is 2 to 2.5 is normal. If it goes 1.5 to 2.5, then it is mild. Valve area 1 to 1.5 and less than 1. Normal is 2.5 to 3.5 square centimeters. Valve area is 1.5 to 2.5, then it is mild. 1 to 1.5 moderate. If this develops, the pressure gradient is usually less than 20 with a peak velocity of 2 to 3 meter per second. Okay. Velocity. Because if this pressure gradient is high, the peak velocity will be high. The speed at which the blood is thrown into the aorta is high. That is what it is telling you. Now more than 40, less than 1, and more than 4 is the peak velocity to say it is severe aortic stenosis. We can also see according to our body surface area. Now, what are the symptoms? Symptoms is demand versus supply. They develop exertional angina. They develop exertional syncope because it's again a fixed output state. A sudden shift in the posture. Suddenly we are exercising. All these things put the patient of fixed cardiac output into decreased cardiac output and they had syncope. And they may have also rhythm disturbance to cause syncope. Usually the dyspnea is less because unlike mitral stenosis, the backward symptoms, patient develops dyspnea first, paroxysmal nocturnal dyspnea second, orthopnea, all these things are relatively later in patients with aortic stenosis. So what is important is angina, syncope, and dyspnea is little less common. So what are the clinical signs? These are the three clinical symptoms we have told: exertional syncope, exertional angina, and exertional dyspnea. Exertional angina, chest pain is little more common. Dyspnea is little less common. What is low volume pulse? Because stenosis, a low systolic pressure, low pulse pressure. We can see a carotid thrill and a systolic thrill in the aortic space. Gallagher-Dian phenomenon is a mimicking murmur of MR will increase with arterial compression. Now we have a systolic murmur of MR. Now you press both your femorals or your brachials. What does it do? It increases SVR. If you press three main arteries, your SVR, don't press carotids. So if you want to press arteries, then your SVR is going to increase. And what happens? Your SVR increase means what happens to mitral regurgitation and what happens to aortic regurgitation. Mass stenosis thing. The murmur will change with the SVR change. Harsh, late peaking systolic murmur radiating to the carotids. Now, if you want to see the pressure volume loop, you can see it is stenosed aortic valve. It is contracting, contracting. So, still it contracts. The ejection volume cannot be that much. It contracts well. There is an LVH, good contraction. Then still it cannot eject much. The volume is still in the LV. It starts to relax. More volume in the LV. Again, it discuss. But slightly this is steeper. You can see slightly steeper because LVH, stiff compliant, non-compliant ventricles, the increase in pressure is more with increase in volume. That is called delta P by delta V. That is called compliance. So this compliance is also less. Automatically the pressure increases and this aortic stenosis. The picture of aortic stenosis where we have increased volume, then increased contraction. That is Frank Starlings. Now, if you have an ECG, it may have LVH with a strain pattern, they may show AF, and if calcification develops, then they show AV blocks. The X-ray may show a small LVH. Valve calcifications can be seen here. Again, I am telling this is normal diastole, normal bicuspid and calcific, normal bicuspid and calcific. More than 4, more than 40, less than 1. The severe stenosis. Normally it is around 2.5 to 3.5 square centimeters. Now we have a gradient is a calculated value, and if a significant LV failure occurs, this may not be truly reflecting the severity of aortic stenosis. Now I am telling again. I'll tell again, don't worry. Now, is it the same for years? No, it may be decreasing by 0.1 square centimeters per year, and the gradient may increase by 10 per year. And we need to repeat an echo. For example, last year echo may not be clearly correct today. We have to treat anemia, see whether there is a coexisting MR, see there is a thyrotoxicosis. If there is systemic hypertension or if there is an LV failure, your pressure gradient may be questionable. I'm again telling you. Now, this is the pressure. Now it is 150. Now this becomes 150. 120 becomes 150. 150 remains the same. Okay. Now this itself is 125 or this itself fails. Now you see here. LV failure, this itself dangerous, or here there is a pressure hypertension causing increased pressure. So the gradient may not be correct. This is what I want to tell. If the LV failure is there, or if there is a systemic hypertension, here there is a problem, or here there is a problem, then your pressure gradient may not be correct. It needs a multidisciplinary approach. Anesthetists, surgeons, and cardiologists. Symptomatic patients with severe stenosis, yes, we need to go for valve procedure first, especially in these days of transarterial valve replacements. Moderate to mild, not mild symptoms. Already I have told what is moderate and what is mild. 1.5 more, 1 to 1.5, or less than 5, or less than 10, or something like that, the pressure gradient. Intermediate patients, non-emergent, non-urgent, can go ahead with closed valve procedures, go ahead with surgeries. This depends upon the decision between anesthetist, surgeon, and the cardiologist. So it is whether the symptom is there, how much is the severity in echo, what is the contractile state. If there is severe LV dysfunction, then it changes. Elective or emergency surgeries, high risk surgeries, we may need to think about either aortic valve replacement or a non-cardiac surgeries, taking into account all these 5 things and taking into 3 more things: anesthetist, cardiologist, and surgeon. Patients with AS who undergo they see Goldman's risk index. So many things are there. First, they identify if there is aortic stenosis, it is dangerous. Yes, we have to correct anemia because exertional dyspnea. I will put this also a first thing in investigations. If there is a patient with anemia, then correct it. Bring from 9 to 12, where dyspnea will decrease. Associated cardiac illness, which is predominant. Coronary artery disease is also maybe associated with this aortic stenosis. So a good pre-medication is needed. ECG monitoring. CVP, does it directly tell the preload? No, because aortic is stenosed. CVP, we can give drugs. PAC catheters, yes, but the possibility of atrial arrhythmias. PAC catheters may correctly tell your preload, especially also your transesophageal echo also may correctly tell your preload or the vascular status. We need smooth intubation and smooth extubation. That is what is a must in general anesthesia. Bronx, everything is usually fine, doesn't do much on SVR, it doesn't do much on your hemodynamics of the patient. Still, we have to think about intravascular injection of adrenaline. That has to be brought in mind. Neuraxial anesthesia without much SVR reduction. So there is a lot of techniques now. Segmental spinal, segmental epidural, sequential epidural. All these things we need to concentrate on preventing a reduction of SVR. Ready for DC version because atrial systole is needed for 40% push. Fentanyl tablet atracurium with agents are appropriate. Intravenous maintenance of fluids and maintain grid. What is the grid in aortic stenosis? Heart rate is normal. Don't make it high as mitral regurgitation or aortic regurgitation. Normal. Preload is slightly on the increased side. Contractility increase or not. Pulmonary vascular resistance be normal. Don't do hypoxia, hypercarbia, acidosis, or probably avoid nitrous. SVR. This is very important. In mitral stenosis, you be careful with the heart rate. In aortic stenosis, you be more careful with your SVR. That is what I am telling here. Now the heart rate is normal. Preload is slightly error on the excess. Contractility normal or error on the excess. PVR is normal, don't make it rise. SVR, this is very important. Afterload should be normal or on the increase. If any reduction in SVR, this is going to be really problematic. So summary, what is it? It's an obstruction to the LV outlet to the aorta. Incidence maybe 3 to 5% in more than 35 years. Severity, I have already told, 1.5 to 2.5, 1 to 1.5, and less than 1. Pathophysiology, very clearly explained. and when to do aortic replacement and maintenance of cardiac grid, where maintenance of SVR is a must. So all my slides can be downloaded free of cost from painfreepartha.com or my YouTube channel. You can go and see Painfree Partha. Thank you very much for patience.